So let's move on to BRAF. This is yet another mutation, BRAF V600E, that is potentially actionable. And Lydia, you want to walk us through sort of the seminal work with BRAF and how you manage a patient with a BRAF V600E mutation?
So as an oncologist, you probably have heard about BRAF mutations in melanoma. In lung cancer, BRAF mutations can also happen, but they're much less frequent than in melanoma. The overall incidence of BRAF mutation in lung cancer is about 1.4%. Also, compared to the melanoma, majority of the BRAF mutations in melanoma are V600E. In lung cancer, only half of the BRAF mutations are V600E. So in lung setting, we were following the footstep of our melanoma colleagues, where they showed that the dual combination of dabrafenib and trametinib is better than dabrafenib alone. So the same studies were done in lung cancer. It was actually a 3-cohort study. The cohort 1 was just dabrafenib. Cohort 2 was dabrafenib plus trametinib in chemotherapy pretreated patient, and cohort C was dabrafenib plus trametinib in treatment-naive patients. And the treatment-naive patients' results are actually quite striking. So the response rate of approximately 70%, and the progression-free survival about 10 months. So currently, dabrafenib trametinib is an FDA-approved combination for V600E positive lung cancer. So that adds to one more molecular testing we have to do, in addition to the EGFR, ALK, ROS, and now BRAF.
And just to make this distinction, it is for V600E, not for non-V600E.
Exactly.
You got the devil's in the details when you're looking at these molecular interrogation reports. But for a non-V600E BRAF, that is not something that we would consider using this combination target.
Not at this point.
V600K, I think this also has activity
one,
against V600K. You know, we've had some other, there's some other uncommon V600X where technically it doesn't meet the approved indication, and then the non-V600X ones as well.
Yeah,
but both E and K can respond.
I agree. I think if it's a V600 substitution, then there's a reasonable chance that the standard therapeutic combination will work. But in lung cancers, the majority of that non-V600 pie is made up of non-V600 alterations like D594G, et cetera. And the punchline is that the standard single agent vemurafenib or dabrafenib or the combination doesn't seem very poised to work for those patients.
And then I would just ask the question, V600E, chemotherapy first or dabrafenib, trametinib? I
stole my thunder.
Yeah.
Oh. No, it's good. No, I was going to ask.
Or chemoimmunotherapy first.
Exactly. Yeah. I mean, I think I would feel comfortable going with a targeted agent up front, but I don't know what other people's thoughts are.
I agree. I would do. I mean, the response rate of 60%, median PFS of about 10 months. I think it's. I usually do dabrafenib, trametinib.
And when you compare, so you remember the cohort B was post-chemotherapy, and response rate was very similar. So really, it doesn't seem to be beneficial for us to give them chemotherapy first. I would agree, just target their therapy right up front.
Okay.
Now, would this be another question to follow up? Would this be a chemoimmunotherapy patient after progression on dabrafenib, trametinib, as opposed to ALK or EGFR?
Yeah, I think we're trying to learn this. I mean, we learned this at one of the sessions at ASCO, the role of immunotherapy in specific genotypes, and trying to gain an understanding about where these fit in, and when they do fit in, where. And is this a smoking patient? Is it a non-smoking patient? I mean, all these now clinical factors are starting to have to be weighed in terms of the decision making. So it's a very complicated world out there.
PD-L1 seems to not be enough, at least on its own, for a lot of these situations. So.
Yeah. Who would have thought we would have so many choices just 5-10 years ago?